Good afternoon, and welcome to Leveraging IT to Reduce Opioid Prescriptions, a webinar and tweet chat from Health Systems CIO, sponsored by Imprivata. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health Systems CIO, and I will be your moderator today. We are having a tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate on your phone or in a separate browser by using the hashtag HSCIOchat, or you could simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, so please submit your questions or comments at any time through the Q&A box in the lower right-hand corner of your screen, and keep the default set to all panelists. And you could download the deck by using the URL on your screen, and it's being sent out in the chat box, and it's at the bottom of our slides. Just so you see how we're going to spend our time today, first we're going to go about 30 minutes with our featured presentation from Dr. Omid Shabastari, Director of Health Analytics with the Carilion Clinic. Then we're going to have a word with our sponsor, featuring Dr. Sean Kelly, Chief Medical Officer with Imprivata and Assistant Clinical Professor of Emergency Medicine with Harvard Medical School. So looking forward to that. All right, so without further delay, I'm going to turn the controls over to Dr. Shabastari. Thanks for joining us. We're looking forward to hearing your presentation.
Thank you very much, Anthony. And thanks for offering the opportunity to present the work that we've done in Carilion. The way we're going to go through this presentation is I'm going to give you a little bit of background. Most of it you are familiar with, some of the overall things that are going in the country. Then I'm going to give you a little bit more context about our organization, Carilion Clinic. The reason for that is it will help you guys to compare your organization and our setting, and then we will have a little bit of conversation about how that context has affected our work and how it might affect if you want to take the similar kind of approach in your organization. And then we will be spending most of the time today about what helped our project to be successful, because those are the kind of things that you want to have in mind and plan in advance, because those hopefully will allow you to have the similar or even better level of success as we did.
Next slide.
Yes, please.
There you go. You got it.
Thank you. Thank you. So with regard to background, is part of the priorities for the government in the recent years. We have heard a lot about the crisis, what's going on, and the government pushing to make some improvements. As you know, with the initiatives from the HHS, there are 5-point strategies, one being access for patients to have better prevention, better treatment, and recovery services. This is probably the category that most of our conversation falls into. With regard to data, better data on the epidemics, that probably goes higher at the population health level. We will have not very much conversation around that. Other things about better pain management, prevention of the overdosage and treatment of them, and research about how we can improve our services about pain addiction. Obviously, those are the items which are very important, but probably less relevant to the conversation for today. Shall we have the next slide, please?
Oh, very good.
Okay. So, as you know, the mortality because of the opioid overdosage are increasing. This is a graph from CDC. You can see that although we have a little bit of reduction on the prescriptions, still the opioids overall prescription are increasing. What probably we see an improvement is around paying attention to other type of narcotics that patients are using and adjusting the dosage of prescription. But then on the other side, for the ones that people have synthetic narcotics, we see an increase. So although there is good attention to the patients who are purely receiving opioids, still the big picture is a problem. As you can see in the darker yellow line chart, that number is increasing, and you can attribute that either because of the increase of the non-prescribed opioid use or because of the other contextual settings that are changing. So we will be talking a little bit about the overall change of context, and these are the factors that need to be considered. The main message here is people are dying more because of the opioids, and that's something that we need to pay attention to. If you compare this even to the overall population growth of the country, the acceleration is much higher, which draws a lot of opportunities for improvement. If you can go to the next one, please. Okay, I managed to move it. The other factor is because this is now a federal initiative all over the country, this is something that is paid attention to. There are a lot of information collected through PDMP or other sources about how the providers prescribe opioids. So as a healthcare system, it's one of our responsibilities to provide the best support possible to the providers, making sure that they wouldn't be taken for any of these initiatives with regard to the amount of opioids prescribed. This is from National Opioid Research Center, GIS-type map that shows exactly which areas the prescriptions are high. You see there are quite a bit of density, especially when you go toward the east-north side of the country. The region that we are representing, the Virginia state, is not as much severe, but it's still something that we are very interested in improving. There are other parts of the country very clearly you can see in this map that has the same pattern. One thing which is very interesting, and I didn't have the slide to put here, but I want to communicate on that, is if you compare these to the population density map, there are some regions that we know, especially around coastal areas, that we have higher population. On the east side, you see some sort of coordination with that, versus on the west side, not as much. And there's areas, especially when you look at the areas around Pennsylvania, there are areas that we see a very high density of the overdose that I'm assuming healthcare systems in those areas can take very good initiatives. So overall, this is the picture that we are dealing with. Most of the physicians are doing a great job dealing with the patients that they do, but mostly probably they are doing in the same fashion or manner that they used to do in the past. They might not know very much how much these changes in the context affects them. There are a lot of legislations coming in. There are a lot of initiatives with regard to persecution of providers because of wrongdoings around opioids, and a lot of increases in non-prescribed opioid usages that might affect the providers. Overall, you would assume that we have two different contexts of care. There are parts of the country which, because of being dominant in the care of those areas, providers would have a very good picture of how their patients are being treated, but especially in the more areas that there are a lot of competition across different healthcare systems, the segmentation of the data around opioid prescriptions might negatively affect insight of the providers about how their patients are being treated and what is the overall picture about patients. Even in some of the bigger healthcare systems, we are very well aware that they might use a variety of different EMRs in different hospitals, especially with newly acquired healthcare systems. So being able to see a bigger picture is something very important, and that's one of the ingredients for success that we will be talking about. So a little bit context about, we jumped fast. A little bit context about our organization. We are a non-for-profit healthcare organization. Our revenue is around $1.7 million. Our headquarters is in Roanoke, which is in the southern part of Virginia. We have something around 737 employed physicians, 7 hospitals, 225 outpatient practices. So as you can see from this data, we have a very strong footprint in ambulatory and outpatient care. It brings us a lot of benefits because a large population of our patients, we are the primary care providers for them, which means that we have better handle on their care. The other thing is we don't have huge competitive in our region with any other healthcare systems. So we have a good confidence that our electronic medical record is a good representation of the status of the care of our patients. The other factor about our system is we benefit from a single implementation of an EMR system with a single repository, so we don't have any kind of segmentation of the care records across different healthcare systems. So that would allow us very much of being able to pull together a good picture of the patient's care. Obviously, we have other types of services like urgent care facilities, home health agencies, retail pharmacy. We have that in place, but many of our patients also purchase their medications from other type of retail pharmacy businesses like CVS, Walmart, and other places that the only way we can access that data is getting the information from the state level prescription dispensing. The population that we deal with is around 1 million people. So again, this piece of information should be something useful for any of other attendees who serve as responsible people for other healthcare organizations to be able to match our context, especially when we are talking about the amount of data and the impact of that on the processing of the information to make a decision how far they can apply the same type of approach that we did. So if we may go to the next slide. These are the factors that we found very useful in success of our project. Consolidation of the data, having impactful communication across the organization, providing detailed level information, the support from leadership, crowdsourcing of the initiatives, clinical support for our providers, and continuous monitoring. So as you can see, this is a combination of IT-related initiatives and also some leadership-based initiatives. So when we talk about the IT-related initiatives, I will give you more insight about how we made that. But also when we go to the management and leadership initiatives, I will tell you the information about how we supported that through providing useful information. So if we may go to the other slide, please. As I mentioned to you guys, we have one EMR with one repository. So our data is already consolidated, and we take that data into our enterprise data warehouse where we can do intensive processing of the information. But having said that, still the sheer amount of data is very high. So to be able to do very frequent refreshes on the information, we use a technology which is called data cubes, which allows us to pre-aggregate the data and be able to report on it very quickly and very efficiently. Next slide, please. So this is the slide that probably I'm going to spend most of our conversation on because this is the approach that proved to be very useful. And it's not just technology, but a lot of political elements attached to it. First thing that I want to draw your attention is we found this approach of a simple scatter plot very useful, and there are several reasons behind that. One fact is all the physicians are very competitive people. They are really interested in making an impact and making an improvement for their patients. So you don't need to push them. You just need to give them enough information. The other factor in this context is by human nature, if you want to criticize anyone on anything, the first reaction is to try to make an explanation. why that is happening. A common thing in this, when you start talking about quality measures with physicians, that comes up is my patients are different. I'm dealing with a different type of patients. I'm dealing with more complex situations. And in many cases, that's true. So as you can see, this chart, there's few elements in there. One, the gray dots that you see, this is a common standard that we use in most of our BI solutions, is the context. So we let each of the physicians or people supervising groups of physicians see the overall context of organization. But the way these BI solutions are set up is in a way that they cannot find out who are those other gray dots. Each of them are a provider. And the blue dots are the ones that falls under the jurisdiction of responsibility of whoever accessing this system. So if they hover over on any of these, they can see the amount of prescriptions and other factors about each of those physicians. The other factor that made a lot opportunity for success for us is, as you can see, we didn't color code any of these. The reason for that is, although when you talk to many analysts, they are very interested to add those additional layers of information to the data, it opens the room for argument. Same kind of things that we discussed before about, no, I shouldn't be compared to others. So we just give them the lay of land, give them the insight about where they are, and leave it to the individual providers and the people who are responsible for them to make a decision whether they should move on any of these or not. We provide, as you can see on that dotted black line, the overall trend in the organization. The blue line shows the trend in that context, so they can easily see, are they doing better than organization or worse? Again, we don't put any judgments or any color coding or any even targets and KPIs. We have done significant amount of work on coming with at least some sort of agreed upon amount of prescriptions based on best practices for different type of procedures, but at least at the starting point, we didn't want to incorporate any of those here. There are three main measures that we found very useful. So some of them might require some pre-work, but I will give you the detail on any of those. One piece is the pill count. Probably it's the easiest thing to look at. We know for sure that there are medications with different strengths, but at least this is something that you can easily pull from any EMR systems. One argument that comes against this is someone might prescribe a lot of pills, but they see more patients. So we also provided another layer of information on top of this that shows the ratios. Again, that could be affected by the type of the case mix of the patients that providers see, but it's a very good insight. The most accurate measure is based on the MMEs, which is morphine milligram equivalents. That factors in the amount of medication in each of the prescriptions, the strengths of them, and all the factors. Also, it allows calculations based on different type of medication, not just countables, like, say, for example, patches, drops, and those things. Helps very much with pediatric-based opioid assessments. One thing that you have to take into consideration is what is the best approach to implement this. Overall, there's two methods. You can easily find some resources that provide information based on the branded drugs. You can also find the information, either your EMR provider gives you this information, or you can find it on some valid resources on the internet based on the generic type drugs. The approach that we took, we decided to go by generic type drugs and calculate based off of that. The reason for that is if there is any new branded drugs added, then it automatically inherits the information from what type of generic drug it's based on, and then you would have much less maintenance on those. Also, the other factor with this is it will allow you to calculate another factor which is called MEDD, which is the morphine equivalent daily dose, and that's something that we'll go through some of the examples later in these slides. It will allow you to also prescribe and control prescription of any kind of medications like naloxone that prevents any overdose conditions. So this approach, you may have this through the EMR vendor provided to you, or you can just build it in your organization. We found this information very much impactful, and I go through the detail of who we made this information available to in the next slides. So if we may move to the next one, please. We provide also the detailed information. So there's other layers in our solutions that allows each of the providers to see individual patients that they are primary care providers for, and which ones are receiving what amount and what is the status of them. This is especially very helpful if you can work that through defining the extent of responsibility at different levels. So our decision in our organization is that primary care providers are responsible for their patients, irrespective of whoever has prescribed opioids for. So they are supposed to keep an eye on their patients. With regard to some of the acute care encounters, our agreement was 30 days after any kind of, say, for example, ambulatory surgeries or inpatient admissions. The primary performer of the procedure is responsible for looking over what is being prescribed for their patients. We had a lot of special situations that we had to deal with. There are people in our jurisdictions who live in rural areas, so our providers were forced to give them enough dosage of prescription at the time of discharge because it was very difficult for them to come back and refill. Those are the kind of situations that mostly your clinical side of the organization can take care of it. So the other things that we looked into is prescription of naloxone and also having a signed controlled substance abuse agreement. This significantly safeguards your providers from legal issues. So we make sure that we keep tabs on those and update the information and provide the detail to providers so that if needed to be, they can make sure that these documentations are obtained from the patients. Next slide, please. So the other factor is the leadership support. We formed in our organization a task force who oversees all the different initiatives, not just IT, but also non-IT initiatives for reduction of the opioid prescriptions. But we made a significant impact compared to other type of initiatives in this task force. We have implemented solutions for opioid reduction, any kind of best practice alerts, and integration of PDMP data into our EMR. Then we have several layers of responsibility based on our organization structure through different departments and sections in each of the departments. They have ongoing conversation and monitoring of the dashboards that we provided to make sure that we take every opportunity for helping our patients. Next one, please. Crowdsourcing. This several layers of approach, practice leads, section chiefs, department chairs, and defining the responsibilities based on our organization structure helped us very much look into the situation in a good high-resolution picture. One thing that you would find in many organizations, there are providers who not only practice in their own context of responsibility, but they have like weekend or, say, for example, afternoon shifts, some sort of working out of the context of their own practice, collecting all the information about a provider and consolidating that for them, irrespective of wherever they serve, again, helped for the education and good insight into the situations of the patients and also the best practices. That is something that we achieved through this hierarchy of responsibility, and it helped us get a very good understanding of how our providers are prescribing and how our patients are being treated. Next one, please. The other thing is the clinical support. We are in an education context. We collaborate with Virginia Tech. We have a Virginia Tech School of Medicine. So a lot of junior doctors or residents and fellows, we made sure that we provide the best practices for them And most of these are integrated not only into our EMR system, but also into our dashboards to help them find the best approaches if they have any patients who are on a high dose of opioids or any other type of context that they need to deal with. They can directly and immediately at the point of care get the best solution and put their patients on the best practices. Also, providing that patient detail level insight for providers help them to take good initiatives rather than being reactive and waiting for patients to come in if they are receiving a lot of opioids. We've worked through processes for making appointments for those patients, making sure they come in, making sure that they get the best support that they need. The other point, as I mentioned, is about the MEDDs, which allows them at the point of prescription make sure they don't supersede any acceptable level of opioid prescriptions. Next one, please. Continuous monitoring. This is not just about giving one instance of information to providers. All of our dashboards and our IT solutions are being updated on a daily basis, so it allows them to keep tabs not only to identify the opportunities for improvement, but also get some sort of insight about how much the initiatives that we are taking makes an impact. And I can tell you that we are very proud with regard to the success on reduction of opioid prescriptions that we've received. And though I would like to take all the credit based on the IT solutions, the fact of the matter is this is, as I mentioned, is a crowdsourcing effort. This is something that everybody worked together. At least I can say that we are a strong facilitator in that context. And next one, please.
Oh, I think that's it. I think that's the end of the presentation.
Yes.
All right.
Thank you.
Excellent, Omid. We really appreciate that. Thank you for sharing all that great information, and look forward to a little Q&A. So go ahead and send your questions into the Q&A box. We'll leave the default set to all panelists, and we will get those in front of Omid. Now we're going to be joined by Dr. Sean Kelly, my good friend, Chief Medical Officer at Imprivata, and we're going to have a little talk with Sean about some things he's up to. So, Sean, first off, thank you for joining us.
Thanks, Anthony.
All right, very good. Sean, you want to tell, I know you're involved with the CHIME Opioid Task Force. Can you tell me about that task force and about some of the things you're doing over there?
Absolutely. I think we all know that many hospitals and people around the country and the world really are struggling with the opiate crisis. So the CHIME Opioid Task Force is a nonprofit entity, 45, 50 plus or so members, formed in 2017, focused really on leveraging IT leadership to catalyze whatever we could to help out with the opioid crisis across the industry, both from the provider side and the vendor side, working collaboratively to really create a playbook of best practices and ways to share those experiences like Omid just described. So there's been a number of things that we've worked on all together. One of the most practical and valuable, I would encourage everyone to go on the CHIME website, and this is open to everyone, not just members, but to check out the CIO and CMIO playbook, which is really a practical how-to guide meant to help those that are just getting started fighting the opioid crisis with background and real-world examples, key takeaways and links to specific resources. A number of the chapters cover some of the tools that we all need to think about using to fight the opioid crisis. And ironically, a lot of things that Omid talked about are sort of covered in this chapter, in these chapters, specifically just creating an opioid stewardship committee to begin with, to get buy-in and leadership and establish that change control and culture change that's needed and getting top-down support. There's a whole chapter devoted to building a dashboard, such as Omid described. There's another one around provider education. Order set maintenance and care pathways is another great technique to go through and really make sure all the default settings and really leveraging the power of IT to make the right thing actually the easier default setting, the easier thing to do as well. The area that I focus mostly on is electronic prescribing of controlled substances, another topic I'm sure near and dear to Omid's heart, where and we can talk a little bit more in depth around this because Imprivata is deep into this, has been doing this for years. It is the leading vendor in the space. This is really leveraging the power of technology to make a transparent and accountable system that's DEA compliant for electronic prescribing, which actually helps patients that legitimately need medications, but makes it harder to divert and abuse or even unintentionally prescribe too many opioids and other controlled substances. Another couple of chapters in the playbook are incorporating PMPs or prescription monitoring programs into the electronic workflow for hospitals and provider systems, patient education, community outreach, and collaboration. In addition to that playbook, the opioid task force has created an action center, and there will be more and more links going up there to useful resources such as state mandates and EHR toolkits, order sets that others have used, and templates, links to things like the CDC for different data sets, results of studies published around these topics, and really just a way for everyone to start sharing best practices so everyone's not reinventing the wheel every place they go. There are a number of webinars already up and running, at least 8 and counting. Having been involved in a couple of those, they're very practical and helpful. So that's just a few things that we're doing on the opioid task force. Very
good. Thank you for that. When you see healthcare organizations going down the road to try and combat this, such as OMID's organization, do you see some common mistakes, some things that people are doing or strategies people are using that you don't think are the best ones or not complete strategies? Anything there?
Absolutely. As you can imagine, there are a lot of learnings that we all have had as we go through this together. One thing in particular, particularly around EPCS, when there's a state mandate or for whatever other reason, provider systems or prescribers are looking at technology they can employ to help curb the crisis, there's a misunderstanding that the DEA requires a second factor, and that's really all it is, that there's either a token or some other factor you need and everything else can remain the same. Unfortunately and fortunately, the DEA is very stringent around what needs to happen to maintain DEA certification. And that involves a pretty lengthy and difficult process that technology can enable and make a lot easier around credentialing providers, giving logical access control to providers, and then actually having an audit trail and reporting ability, as well as usable system that's linked into existing EHR medication prescribing modules. That can be a tall order with improper technology, but luckily with really good technology, it actually becomes much easier. And I think that would be kind of the second major mistake, is to just try to go for compliance and not address the workflow issues underpinning all of the underlying problems here. Because I think in reality, you really got to account for doctors and other prescribers, nurses, patients, and family members to really actually make things better for them rather than worse by putting in such a system. And, fortunately, that is available out there now.
Very good. Opioids are a necessary part of medical care. I mean, I assume that's the case, that this is not something we can just do away with, which is what makes it even trickier. If it was something you just wanted to remove and prohibit, that'd probably be easier than something you have to manage. So talk a little bit about that, the fact that they're not evil in and of themselves, and they do have a medical purpose, but they need to be managed better than they have been, and that's what we're all trying to do.
Absolutely, Anthony. These are important medications, and while they certainly have high risk and high potential for fraud and abuse, as you mentioned, they're very potent and oftentimes very necessary. So any good technology really makes it easier for prescribers to get the necessary medications to patients who legitimately need them, but harder for those trying to fraudulently prescribe them or divert or abuse them and feeding into that addiction cycle. So with EPCS technology, for example, which is what we know the best, a good system is actually very well received by prescribers and patients alike, and satisfaction really goes up. If you think of, for example, a parent with a child with ADD, attention deficit disorder, they have to get controlled substances to treat this refilled on a regular basis. And what used to happen is they would actually have to physically go in and get a paper script, or the doctor would write paper scripts that are post-dated every 3 months. And they would have to then carry these prescriptions to the pharmacy, hand them in, wait around, get them filled, and pick them up, despite the fact that 90% of their other medications, 90+% of their other medications are actually sent directly to the pharmacy. So, actually patients and family and prescribers really love it when there's a good technology in place that actually allows it to be easier for them to get the medications they need. And the last thing a long-term cancer patient needs, who's in incredible pain, is to have to go in and get a paper script that they have to carry over or have someone else bring over to the pharmacy to get filled for them. And so, your point is totally correct, and there's a huge separator between poor technology and good technology. And so I would encourage every provider system out there to do the due diligence on these systems to make sure that, what is the track record? Are providers really satisfied with it? Places like Geisinger and others have put in these systems and actually found not just increased satisfaction and decreased burnout for providers, but increased patient scores for satisfaction and even dollars coming back to them, things that we never thought of as a vendor. For example, Geisinger found over $1 million a year, $1 million a year in ROI, just in the fact that all of the callbacks to the various help centers around lost prescription and refills, that workload decreased. So there are a number of benefits here, including just satisfaction and usability.
Okay. Any that policies in flux around this all the time, and very important not to run afoul of policy and be in compliance. So what updates can you give us around the policy issues here?
Yeah, there are a lot of policy updates. So I guess most importantly, there are now 27 states that have passed EPCS mandates. So it behooves every provider system out there to check with their own state or the states surrounding them, see if there's a mandate on the books, and if so, when it takes place. A lot of these are already effective. Some of them take place in January of 2020, some in January 2021, and obviously you just need to check with your own state. The good news is most of these states, the EPCS language essentially says that all prescriptions need to be sent electronically if they're controlled substances after a certain date, and they're really modeled after the DEA regulations. So as long as provider systems and providers are compliant with DEA regulations, the state is mandating that they send the prescriptions electronically after a certain date, and they often have waivers, a waiver process where exemptions are allowed for certain things. And even that language can be similar state to state, but you really need to check your own state. We have on our website, we continuously update that and can link you to that if you want to go to Imprivata.com, and we can update you on that. In addition to the state mandates, there are some other things that everyone should be aware of. First of all, there's a federal mandate that governs the reimbursement under Medicare Part D. It's called the Support for Patients and Communities Act. And what that says is that effective January 1st, 2021, any prescription that is of controlled substance, if it's going to be reimbursed by Medicare Part D, has to be electronic by that date. And so that's a pretty stiff penalty if you can't get the prescription filled if it's not electronic after that date. Interestingly, the Walmart pharmacy is one of the largest pharmacy providers in the U.S., has also said that any controlled substances filled after January 1st, 2020, so that's coming up pretty soon, that those actually need to be electronic as well. So we see a lot of hospital systems moving, if not for state mandates or because it's the right thing to do or because of Medicare Part D reimbursement later, they're doing it because they know a large percentage of their patients are trying to get their prescriptions filled at Walmart. And after January 1st of next year, they won't be able to do that unless they have a controlled substance electronic prescribing system in place.
All right, very good. Thank you, Sean. Now we're going to go to our general Q&A. So again, if you have questions, send them in, and we will look at them. So let me get to our first audience question. And Dr. Shabastari, we'll give you a first chance to comment on this, and then we'll go to Dr. Kelly. What data elements of the prescription are most useful? Are we fully leveraging the, quote, last fill date, end quote? Should RX fill notifications be mandatory for EPCS? If fill date is other than written date, do all EMRs replace or modify start date to reflect fill date?
That's a very good question, Anthony. Most of the elements that we are using is looking at the overall ME level, as I mentioned, that includes the counts and the type of the prescriptions. As you mentioned, EMR systems are quite different. Some EMR systems enforce the prescriber to put an end date. Some of them, they do not. It is also dependent on how healthcare systems are putting any kind of customizations in place in the EMR solutions. But overall, it's very helpful, especially we have a lot of opioid medication collection initiatives that we make sure that if people haven't used the opioids, we have some processes in place to go back and collect them. Putting an end date on the prescription helps coordinate some of those initiatives very well. Thank you.
Sean?
Yeah, I guess I would say great question around the specific issue of fill and end dates, which I think Omid hit directly. I'd sort of take it up a level and say, from a general perspective, this question illustrates a framework to think about this problem. And if you think about, for example, the chapters of the playbook we just talked about, you can walk through several layers that a provider system and prescribers need to consider when being compliant, first of all, with regulations, but also making solid policy that's good for patient care, quality, safety, and actually positively affect the outcomes in the opiate crisis. And so, first of all, you need to consider the technology in your particular hospital and your particular systems. Is it DEA compliant if you're creating electronic prescription of controlled substances? There are federal and state mandates and regulations that we talked about. Then there are local policies, either from your hospital or local entities that need to be accounted for. And then there are just best practices and departmental policies. And, that can get pretty complicated if you have good technology in place. And, for example, if you go through the steps and you talk through and work through those chapters we talked about, are creating an opioid stewardship committee so there's governance around these things. You can make sense of it and decide what your own hospital and practice policy is and enforce it. You can build a dashboard like Omid did and others where you can actually be visible and see it. You've educated providers. You've done the order set maintenance and care pathways guidelines, and so your default settings are actually set correctly so the providers don't even have to think about it if you do this right. The provider default setting as they go out the door, either from an office visit or from the hospital or post-op, is actually what you want it to be according to policy. If you have a good EPCS and other systems in place, that it's actually compliant with DEA regulations, state regulations, and even with your hospital policy. And most importantly, you can prove it because you have an auditable, reportable trail of all of that that is easy to reproduce. And on top of that, you're going to go ahead and incorporate with PMPs. You're going to have patient education and other provider education to complete that circle and change management that Omid was talking about. So this is a great question, a very specific question, which illustrates, you could ask several specific questions like that. If you have a framework in place, it's much easier to address those specific issues because you can run them all through that process and there's a governance in place. And then I would also add that we're refining this process nationally as we go, and there are organizations and entities at the CMIO level, the CIO level, and analytics levels where we're actually taking some of these hot spots and then putting it through a process so that nationally EHRs and other medication modules, prescribing modules can be improved as well as the standards set for the transfer of that information properly to the retail pharmacies. So great question.
Very good. All right, we're going to go with our Ask a Co-Panelist feature. So, Sean, I'm going to give you the first opportunity. You have a question for Omid?
Omid, what's your next step? You've done so much already. You've had a lot of people asking you, can you show me this analytics or that out of this data set? Where are you going next with this? Because I just love what you've done so far.
Thank you so much. The main initiatives that we are following is coming with some sort of standards of best practices on the amount of opioid prescriptions. We have gone through one exercise of trying to lower down the default level of prescriptions, and we were very successful on that. But we are very much aware of variations based on the needs and intensiveness of the procedures performed on the patients. There are some suggestions for some specific procedures, but I haven't seen something comprehensive that says at least this is the starting point as a default for prescriptions for different type of procedures. So that's what we are trying to do. The second thing is, as I mentioned, the continuous monitoring and follow-up with different opportunities. In some cases, not just reduction of opioid prescriptions is something that you would observe. Based on the initiatives around opioids, we are doing quite a bit of detox clinics, which automatically increases the amount of opioid prescriptions. But then at the same time, we are looking at additional factors. For example, the overdose number of cases coming to our EDs. And I'm sure that's something that, Sean, you've seen very significantly during your practice. So I would also love to hear from you what you advise from a practitioner perspective. What do you see are the clinical opportunities?
Yeah, thanks, Omid. As we discussed, I wear one hat, which is I'm actually a practicing ER doctor. So unfortunately see this crisis firsthand, and it definitely gives you perspective how real this crisis is, because just about every shift we see multiple patients affected by this, and sometimes, unfortunately, it is an overdose. And we've had to tell parents that their 20-year-old child came in after the experiment, never doing drugs, and being bullied into taking a fentanyl patch and putting it in their mouth, and suddenly they felt strange and were embarrassed and went in the corner and they stopped breathing. And these things happen, and unfortunately they happen literally on a daily basis. So I would beg the informatics people that are around and helping with this problem. We need to account for the reality of the situation, how urgent this is, and even though there are mandates, and certainly we do it for that reason, but there's really good technology now that makes these systems usable, and I can't stress how important it is to make the right thing to do really easy to do. And so it takes a lot of work to go through, but once it's done, it really pays off that you really go through your order sets, you go through your messaging, everything from default settings when someone is sent out the door to the discharge paperwork, simple things like explaining to patients that even if we're going to give you a strong pain medication, it can be addictive, and you just had surgery, you may be expected to have some pain. This is a PRN or a take only as needed medicine. You shouldn't expect to have to take it. It's okay not to take it. And this takes some scripting. This takes some work. As Omid said, it takes change management. It takes policing. It takes really watching after it and helping the human side of this for behavior modification. And so I think we all need to remember, as technology experts, we can really affect change. And the devil is in a lot of those details. And it really matters to the frontline clinicians. If the default setting is correct, then it becomes actually easier for them to use the system than not use it and work around it. Ultimately, we care most about patient care, and we will work around systems that are put in front of us that aren't effective. But if they're effective, then we'll absolutely use them.
All right, very good. One more audience question I want to get to before we let you go. Let's start with you, Omid. I have heard it suggested that long-term opioid use should be managed by pain specialists only. Do you feel this proposal has merit?
So this is very similar to any kind of progression of subspecialties in medicine. Obviously, pain management specialists are more equipped with knowledge around doing this. What we found is there is limitation of resources around that. If we had enough people that could help with that, obviously it's a very good thing. The other thing from the patient behavior perspective is patients are very receptive of what their direct care providers advise them. So although pain management specialists are a great resource, I believe more in that direction of crowdsourcing and making sure that every provider feels responsible in this and not just pass it along to a pain management specialist. Having said that, there are patients that we know continuously will benefit from this, like severe chronic pain patients. They definitely need to be supervised by pain management specialists.
Sean?
I agree wholeheartedly. I don't think realistically it's possible to get enough pain specialists out there to really effectively treat everyone, as Omid said. I also agree that every care provider needs to be educated up and be competent on how to manage this. And I think I would stress as well, the focus when talking about opioid use and prescribing is to talk really mostly about opioid use and prescribing in treatment of pain. And what's fallen by the wayside is how many other ways there are to treat pain. And, they've become sort of, quotes, alternative methods, but, physical therapy and stretching, massaging and non-opioid medication treatment, those should be the mainstays of treatment. And so a lot of this is culture change, and a lot of it is education. A big part of it can be technology, and some of it's policy related, right? Like if Medicare will reimburse for a Percocet prescription and not for PT, well, that's a problem, right? So there are layers and layers to this crisis and addressing the crisis, I think, but we all own it. In the ER, for example, we never treat long-term opioid use. In fact, we cap our number of pills and morphine equivalents and all that. And more importantly, we actually agreed recently to become Suboxone prescribers to start medication-assisted therapy for those that we identify as being in that addictive cycle, for the very reason that we need to bridge them to a specialist to follow them and manage this properly. So like it or not, patients hit our ER, they hit their doctor's office, and they need help, and everyone owns this. We all own this.
It's an excellent place to stop for today, and a great conversation, and I'm sure helpful to a lot of people. Regarding continuing education, attending our events gets you one CEU towards the CHIME CHCIO certification program, so let CHIME know you were here, and if you've asked us to do so, we will. You receive an email when an on-demand recording of this event has been posted to our YouTube channel. If you want to sponsor an upcoming event from one of our lists or book a custom event, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for one of our upcoming webinars. So with that, I want to thank our speakers very much today, Dr. Omid Shabastari and Dr. Sean Kelly. I want to very much thank Imprivata for sponsoring this event today. And I want to thank you for attending. So with that, everyone have a wonderful day. Thank you.
Thank you, Sean. Thank you, Anthony.